Friends, today we are going to discuss a chilling situation. But before that, let us start with a universal prayer. The situation is that of crisis. Crisis which can happen without any mistake on our part. Crisis where the system just refuses to budge. First, let me sensitize you to that crisis by a case report, a true-to-life case report. We report the case of a 33-year-old pregnant female with severe preeclampsia who developed serous retinal detachment and HELLP syndrome. Following delivery by caesarean section, there was a spontaneous resolution of the serous retinal detachment with residual pigmentary changes of the retinal pigment epithelium. The patient did recover a normal vision. The retinal detachment is not what we are going to discuss, but what we are going to discuss today is HELLP syndrome. The discussion will be in a different format like this, a format where we will be in a form of question answers. I have received questions from all over the country over a period of time on HELLP syndrome. I had requested by email. And now that we have got enough questions, we are going to discuss your questions to my answers. The bias will be completely towards clinical orientation, approach, and management. And so I have selected those questions which are in tune with this thinking. First set, early detection and diagnosis. Your questions, my answers. And the first question which I got was, this is not necessarily the first question received, but the first question which I selected, because this is the way the case will evolve, and so it will fit into the plan of things. At how many weeks of pregnancy does one get HELLP syndrome? And this question was sent to me by someone from down south, where she said that she had a HELLP syndrome as early as 20 weeks of pregnancy, which others refused to accept. What is the right academic answer? Not what I think, but what actual reality is. Patients of HELLP syndrome usually present between 28 to 37 weeks of pregnancy. That means third trimester or immediate postpartum within 7 days of delivery. For HELLP syndrome, I was asked, sir, what risk factors we can look for so that we are prepared for it, and at least we are ready to expect it. Well, the risk factors for HELLP syndrome differ from those associated with preeclampsia. Though early onset preeclampsia, not all preeclampsias, is now known to be a high risk factor for HELLP syndrome. Also, history of HELLP syndrome, history of diabetes, history of obesity increases the risk of a subject to HELLP. Besides this, age being 35 years or older, multiple pregnancy, having a chronic cardiac condition, or say autoimmune conditions like SLE, these can cause HELLP syndrome. What is the first presentation of HELLP syndrome? And this is essentially a clinical situation, a clinical answer, which will make you alert. The hallmark of HELLP syndrome are not petechial hemorrhages or anything. The hallmark symptom of HELLP syndrome includes right upper quadrant abdominal pain or epigastric pain resulting from liver distension. This is where we can be caught off guard. Why? Because in pregnancy, epigastric pain is commonly complained of, because we know that this is reflux esophagitis, which is so common in pregnancy. But the pain of HELLP is not because of this. Epigastric pain results here from liver distension and not from the reflux of pregnancy. Therefore, when you palpate, you will be able to elicit tenderness right up to the entire liver zone. Whereas in the reflux, you will find it only confined to the epigastric region. And that could easily differentiate. Also, there will be non-specific symptoms like malaise, nausea, vomiting, weight gain, and various others. Then I was asked this question. Sir, what are the minimal diagnostic aids, minimum features from which we can pick up? Many times this question still comes in India, that we have limited resources and limited access to resources and investigations. So what will be the minimum features with which we can say, yes, this is HELLP? Minimal features to diagnose HELLP: hemolysis, elevated liver enzymes, and low platelets, is a raised blood pressure, low platelet count, and blood test for enzymes that will show cell damage, which we all know. One of the classical ones, reliable one, is LDH, lactate dehydrogenase. Besides this, liver function test, bilirubin level, and urinary test for proteins. These should alert you. Don't require any very great investigations at this stage. Also, platelets will be essentially less than 100,000 per cubic millimeters. Associated with LDH greater than 600 and a bilirubin greater than 1.2 should give way to HELLP syndrome. Further, you can get it more elaborately diagnosed with estimation of liver enzymes like SGOT and SGPT, as well as AST, what we call as aspartate aminotransferase, and ALT, alanine aminotransferase, which will be elevated more than 70 international units per liter. Or if the laboratory gives you the normal, then it will be more than twice the upper limit of normal concentration. This much will be enough and will make you alert to HELLP. Now let us take the next question. I was asked, sir, what are the differential diagnoses you will consider? There are three main differential diagnoses: acute fatty liver of pregnancy, thrombotic thrombocytopenic purpura, and hemolytic uremic syndrome. I have no intentions to confuse you, and therefore we will take the most consistent differential diagnosis here, one, and that is AFLP, or what we call as acute fatty liver of pregnancy. Now see the differences. Compromise in kidney function will be common with AFLP, but less common with HELLP syndrome. Other features may be similar. The bilirubin portion of the laboratory test is increased much more with AFLP, but much less with HELLP. I told you 1.2, 1.3, 1.4. This in AFLP may go much, much higher. Hypertension may not be present at all in AFLP, although they will often have proteinuria. Hypertension is a very consistent association with HELLP syndrome, though not necessarily always, no, almost always is the right word. One of my teachers, who is no more, surgery, he used to tell beautifully that don't express your arrogance in medicine ever by telling never or always. The right phrase is usually never or almost always. And in the light of that, I am telling you that almost always preeclampsia is present in HELLP syndrome. Now, having seen the diagnosis part of it, and some points will come in the prognosis part also, we come to the questions which I filtered on management strategies. The fundamental treatment is to deliver the baby ASAP. This ASAP, MAGA, FOMO, these are the words, FOMO, MAGA, these are all short forms which have become very popular with the current generation. And therefore, we also become infected by these. So the main treatment is to deliver the baby as soon as possible, even if it is premature. However, there will be a set of subjects who will develop AFLP later in postpartum within 7 days after delivery. In them, the delivery portion is obviously not to be considered, lest other principles remain the same. And what does it include? Control of blood pressure, blood transfusions, specifically platelet transfusions, anticonvulsants like IV magnesium sulfate to reduce the risk of seizure, and blood tests to monitor liver function and platelet count. And wait for the system to recover on its own. There are some treatments which I will tell you in the due course, which may not be available everywhere, but are surely effective. I will be coming to that soon. But when you are monitoring these patients with these treatments, say you have carried out the delivery and now blood pressure medications are given, you are giving platelet monitoring, it becomes very important. So that is where I was asked this question, sir, how much minimum platelet count should we be comfortable with? The answer is based on scientific evidence that patients with a platelet count greater than 40,000 per cubic millimeter, as low as 40,000, are unlikely to bleed. Please relax, don't start jumping. Don't start jumping. Having it managed its medical part of it, we come to the obstetric management. And the basic management still remains the same as which I saw when I was an undergraduate decades ago. And that is obstetric management, the sheet anchor is cesarean section. In past, delivery in patients with HELLP was routinely accomplished by cesarean sections. And it has also been found that patients with even severe HELLP, completely deranged enzymes, critically and scarily low platelets, and hepatic derangement with superimposed DIC, even a superimposed DIC or a gestation less than 32 weeks also should be delivered by cesarean section. Ask help of a very senior, experienced obstetrician who will not be afraid to carry out a cesarean section like this. People like me, we have carried out cesarean section in such superimposed complications many a times. So find out people, keep them in your memory list, and if you have a bad luck of getting trapped in HELP, ask for their help and they will perform the seizure, you assist them. They will get out fast with platelet line running, blood line running, and get out, and tight stitch is taken because this is platelet bleed. So there will be oozing, and this oozing point, don't get alarmed. With platelets rising, this oozing will cease. But cesarean section still is the sheet anchor, and therefore, if you are looking for a change there, sorry, no change. Now I was asked one question, sir, we are monitored this patient is on, we have done a scissor and now we are monitored. So what should we keep a watch on to know whether there is an improvement or deterioration? And that was your question. To which the specific words were, what parameter should we keep a watch on while managing a subject of HELP? The answer is LDH and platelet count. Platelet count less than 40,000 is scary. But if they have started rising, like we see in dengue, the same way, a rising platelet, relax. Lactate dehydrogenase. LDH levels of 600 IU per liter or less are considered as normal for pregnancies. So be comfortable. LDH levels are very reliable because not only they help in diagnosis, in prognostication and the progress of the disease as well, as to, if you want to know if the disease is increasing in severity, LDH is a much more reliable marker than only platelets, and an increasing LDH is a sign of increasing severity of the disease. We now come to a very promising area like this, a promising new day. And that also is based on a question which I was asked, sir, do you recommend plasmapheresis for subjects with HELP if available in that city? Early plasmapheresis surely improves treatment outcomes in patients with severe HELP syndrome. Let me give you some interesting data. In patients with HELP syndrome, where plasmapheresis is performed, the range of platelet after 24 hours increased by 2.2 times on an average. After another 48 hours, means 24 hours of doing the plasmapheresis, 3.6 times, and after 72 hours, 4.5 times. You can realize if the platelet count was 40,000, it will soar to 1.8 lakhs easily if plasmapheresis is done. And that is not only one parameter, LDH, our friend. Within 48 hours of doing plasmapheresis, LDH levels will fall below 1,000 and start declining. So yes, there is surely a role of plasmapheresis. The next question I had very much expected. Any role of steroids? Because steroids were quite popular in HELP. 2023 December, hardly a year ago, a very nice study has come, which has shown the answer to any role of steroids, no. This study compared the efficacy of corticosteroids in patients with HELP, revealing that corticosteroids did not provide any significant benefit in clinical outcomes for pregnant women and newborn both in conditions of HELP. So, as is shown here, it does not help. But there is one thing which helps. And there we can say yes, yes. And what is that? Has aspirin any role? The role of aspirin in preventing HELLP is for prevention, not for treatment. Successful preconception and post-conception and conception prophylactic treatment combined of aspirin and low molecular heparin in cases of antiphospholipid antibody syndrome with subjects with prior HELLP have been reported with very good results. So this brings us prior HELLP, scary. This brings us to the last question, and that is, once a HELLP, always a HELLP? The answer is on data. All studies agree that HELLP mothers have surely increased risk of pregnancy-related complications, including early onset preeclampsia and others, and HELLP in future pregnancies. So friends, HELLP is a dirty, not a pleasant thing to handle, like this habit. When you encounter HELLP, seek help. HELLP, HELLP and HELP are brothers. One goes with the other. And at the same time, while you watching this video will increase your alertness, will help in handling these cases. You in full command by your knowledge that I know what is to be done. And how did that come? By being well informed, well read, and with new modalities like this, well seen and documented, you will be very easily, I will say, comfortably able to handle HELLP. HELLP with its scare remains. But if you are in full command of knowing what is happening, well informed, well read and alert, then your approach will be totally different from someone, a routine obstetrician, who just manages as if it is some routine condition. And this will help us satisfy this promise of ours.